So good afternoon and welcome to your BenCo webinar, Gateway 2021, Crossing the Bridge into Dentistry. My name is Kay Hupp and I will be your BenCo host for this afternoon. Before we get started, we just want to go over a few CE guidelines. Number one is that each person needs to sign in their legal name in order to receive CEs. And what I mean by that is the name that's on your license. Each person also must watch the webinar on their own device. And that way we know that you're logged in because it's all time-stamped. If you're watching the webinar from your cell phone and you actually push the link where you can actually see us, that's perfectly fine. But if you're listening on your cell phone, all we can see is your telephone number. So what we'll need you to do is email me your name, your telephone number so we can cross-reference it, the title of tonight's course, and you're going to email that to practicecoaching@benco.com. Again, that's practicecoaching@benco.com. Now, that's only if you're watching from your cell phone and you're dialing in and you're listening. So that's the only reason that you need to actually send me your telephone number. Also, at the end of the webinar, you're going to be receiving a survey when we send out your CEs. We would love to know what you think, what else you would like to see, and definitely your input. So please make sure that you fill the survey out and send them in when you receive your CE certification. Also, at the bottom of the screen, you'll see a Q&A button. Please make sure that you enter any questions on the Q&A button, and we are going to make sure that we try to review those questions live at the end of the webinar. So with that being said, I'm honored to introduce my amazing boss and one of the managing directors of BenCo Dental, Chuck Cohen.
Kay, thank you very much. I am coming to you live from my car because things have to be done and people need to go, and I'm going to join a little later. I have a specific job this evening, and that's to introduce our sponsor. But before I do that, I just want to say, first of all, thank you to Kay and the BenCo Practice Development team for putting this together. And I want to give a preview to say that Dr. Krieger is really one of the most exciting speakers that we've had. He has a tremendously successful practice in New Jersey and really understands how to integrate implants into a practice and turn it into a real moneymaker and success. But that's not my job. My job is to introduce Catherine Galvin. Catherine is the VP of Marketing at IDS, a division of biotech, and one of the most prominent manufacturers and distributors of implants in the US market today. She has over 25 years of experience with dentistry, and she is going to talk for a few minutes about IDS, and then it is her job to introduce Dr. Krieger to you and get things started. So thanks everybody for being here this evening. Thank you, Catherine and Dr. Krieger, for being here also. And Catherine, thank you on behalf of BenCo to IDS for sponsoring tonight's program.
Thank you so much, Chuck. Well, good evening, good afternoon to everyone. As Chuck said, I'm Catherine Galvin. I'm the Vice President of Marketing. I apologize that Carrie could not be here tonight, but I'm told I'm better looking. So I'd like to thank BenCo for the opportunity to sponsor Dr. Krieger's webinar on the business of profitable and efficient implant dentistry and introduce IDS, a biotech company. So IDS merged with biotech in early 2021, so just this year. Biotech Dental is headquartered in the south of France and founded in 1987. It's over $100 million company, and the Contact line of implants is the highest selling implant in France and other countries in Europe. So our goal is really to drive the future of dentistry using digital solutions and artificial intelligence to improve patient outcomes while still being affordable. The products range from dental implants to smile design and planning software to photomodulation. And all this will be available through your friendly BenCo territory manager. In addition to Biotech Dental's global portfolio, IDS also offers a Reflect line, which is a mirror image of direct brands at a much lower price. Those brands include Replace Select with Conical Connection, Nobel Active, Biomet 3i Certain, Zimmer TSV, and Astratex TX. And our upcoming Accelix implant system for accelerated implant therapy. It's fast, strong, easy, and affordable. So while today's webinar will teach you about being profitable and efficient, you'll still need to start placing implants. So with that, we have upcoming a live surgery course in July, US, and we treat live patients, and better yet, the patients are all US veterans that receive free care from Smile Faith, a teaching institute located outside of Tampa, Florida. And with your paid tuition, not only do you gain incredible experience in 21 CE credits, but we'll have a promotion to receive a free surgical kit, motor, and 25 implants. So let's get started on incorporating implants profitably and efficiently. I will take any questions and I will introduce Dr. Krieger. So I'm going to stop sharing my screen. And bring up Dr. Krieger's. All right. There are no questions. So Dr. Matthew Krieger graduated from New Jersey Dental School in 1998 and started his practice in 2003 from scratch and built it to a full-time practice in just 1 year. He's the founder and CEO of $1 Million PPO, a dental practice management coaching and consulting firm. He lectures in practice management, CAD/CAM dentistry, and highly effective clinical efficiency coach. He's an active member of the ADA, AGD, AACD, and ACE, and earned over 600 hours in continuing education in all aspects of clinical dentistry and practice management. Please welcome Dr. Krieger.
Thank you very much. Thank you, everyone, for joining us this afternoon, this evening, depending on where you are. Thank you to IDS, and thank you to Benco for having me. It's my pleasure to be here. We have a lot of material to cover and not a lot of time to do it. So I'm going to jump right in. I'll try and answer questions as they come up if they do, but if not, I will make time to stay after to answer questions. And I'll provide you guys with an email contact directly for me, so that if you do want to email me after the webinar, you're certainly welcome to do so. Okay. Now, why can't I advance my slides? There we go. So real quick, I'm a general dentist in Northern New Jersey. I am also a practice management coach. I founded $1 Million PPO Coaching and Consulting about 10 years ago. I lecture nationally on practice management, as well as CAD/CAM integration and implant integration. You know, we have clients all over the United States. We work mainly on the practice management side, but we do also some clinical coaching. But my primary effort is in my private practice in Northern New Jersey. So I'm in a suburb of New York right now, waiting for the bad weather to hit. Again, thanks to Benco and IDS for having me. And let's get started and talk a little bit about my practice. So I don't have 2020 stats up because of COVID. And I think they would be misleading, although we didn't miss a big beat here in New Jersey. We were able to be open pretty readily. This is what my private practice looks like, just to give you a sense of what we're doing here. I have a small 4-operatory practice. I have 6 full-time team members. We practice general dentistry, a lot of implant placement, a lot of extraction graft membranes. We do have a nice surgical practice. But it is a general dental practice. We see little kids 3 years old all the way to geriatric patients. And what most people find interesting about my practice, and one of the reasons I'm able to lecture and really help so many dentists is, you know, the the level of revenue that we're generating, just about 1.7 million. We're actually on track this year to be at 2 million, with an overhead under 60%, and doing that on a 24-hour clinical week, and really only over 48 weeks a year. So our profit really is all about efficiency in our practice. And that's why today's topic of implant implementation is really a combination of just general business information and practice management, as well as efficiency. The key to business, and certainly the business of dentistry, when you involve any discounting, insurances, PPO participation, the key to successful business in dentistry right now is all about efficiency. And so that'll be kind of the focus of our, call it, hours discussion this evening. So first, I want to start with generally, how do we grow a practice? If you're on this webinar, you want to add implants to your practice, perhaps, and perhaps you just generally want to grow your business. To be honest, you have to be growing your business every year. If it's not growing, it's dying. There is no such thing as flat in capitalism. You're either up or you're down, because the economy and inflation are always moving. So there are 3 ways to grow a practice. The first is to do more procedures. So keep doing exactly what you're doing, but sell more of it. So imagine you're a shoe store and you sell 100 pairs of shoes a week, sell 150 pairs of shoes a week without adding any time, and your business has grown. The second way to grow your business is to add more procedures to your practice. So that's the topic of today, adding implants. Again, if you're a shoe store and you're selling shoes and you decide that you're now going to sell hats or socks, you've now added a new inventory that you can sell on top of what you're already selling. So you have the same patient base, the same customers. They're able to buy more variety from your business. And then the final is to add more patients to your practice. That has always been, for general dentists, I think the sexiest, most obvious way to grow their business. They are constantly asking me about marketing and how do I add patients and how many new patients should I be getting and where do I get more new patients? And I think there's companies out there that talk about new patients this and new patients that. Adding more patients to your business is great, but it is, of all of these 3 methodologies, the most expensive, least predictable way to grow your business. I've ranked them in order: do more procedures, add more procedures, and add more patients. I've ranked them in order of ease and expense. And so, doing more procedures is the easiest. You already have patients. They're coming in tomorrow. You can do more dentistry on them. Adding more procedures involves perhaps training, as was alluded to. Perhaps it involves adding an armamentarium, purchasing an inventory. So again, doable, but perhaps a little bit more involved. And then adding more patients really involves generating, creating, and sustaining a long-term marketing strategy. So today we're going to be talking about adding more procedures. By far right now in general dentistry, implant placement in the general dental practice, as well as the CAD workflow, is really where all of the new procedures are being generated for general dentists are. I know you're going to hear a lot about Botox and Invisalign and sleep and all of those things, but from a purely general dental sense, implant placement in the general practice is where you're going to get your best bang for your buck in adding procedures. And I'm going to talk a lot today about implants, but I want to be clear, you really can't talk about implant placement without talking about extractions, ridge preservation, grafting, site preparation. And so when we talk about implants, let's really make sure that we hone in on talking about the entire process of taking a patient from perhaps toothache or trauma or emergency or failed dentistry all the way through to new tooth. Since most of you, I'm assuming, are not oral surgeons and will therefore not be referred edentulous patients who need implants, you will have to take your patients through kind of their normal workflow. So let's talk about implementing implants into the practice. Now, one of the assumptions that I have to make in doing so is that you have the proper training in armamentarium. If you're not there yet, you certainly have opportunities through Benco and IDS and companies to the like to sit down and talk to their reps about where to get good training and how to equip your practice to begin implant placement. I'll touch on it a little bit, and I'm happy to answer questions about how I incorporated implants as far as the training and armamentarium in my practice. And you can ask them now or email me at the end, and I'm happy to share. But as far as implementation, let's walk through, assuming that you have the appropriate training. So first, we're going to be talking about diagnosis, and then we're going to walk through treatment planning. And that includes the diagnosis of whatever is wrong with the tooth, all the way through to what kind of restoration we're going to be placing, implant versus FPD versus RPD versus no restoration. How do we present these cases to patients in the most effective, efficient way? How do we make a financial arrangement so that when we're doing implants, we're making money from them? How do we sequence the treatment? What are the clinical protocols that we, the doctor, the team, the administrative staff need to follow? And then once the implants are in, kind of what do we do? Are we just letting these people go? Are we following through recare? Do we have a recare program for our implants? And then a brief discussion today about marketing, although with the time allotted, I think we're going to spend most of our time on implementation, okay? So first, diagnosis. So, you know, when I talk about diagnosis, it's almost impossible for me to not talk about image and implant planning. So you're going to take x-rays of your patients. They're going to present either with emergencies, you know, or through routine care as new patients or as recare patients. They're going to potentially have dental disease. There are lots of root canals out there that are failing. There are lots of people with broken teeth. There are lots of people with existing missing teeth or with removable dentures or partial dentures that are unhappy with those dentures. So collecting data at your initial consultation, knowing which kinds of patients are coming through and why they're coming through, and most importantly, being prepared beforehand so that you're most efficient with what kind of imaging you want to be doing and what your imaging protocols are. I find in a lot of offices that new patients, existing patients are coming in and in need of implant dentistry. And a lot of teams and doctors, quite frankly, seem to be confused about what the image collecting, data collecting protocol is. What do we need in order to be able to make a diagnosis and create a treatment plan and have a discussion with the patient? So there's lots of scurrying around the office and taking an x-ray and then taking a pan and then coming back and maybe we're going to do a scan on this one, but not on this one. And, oh, I didn't take as many x-rays. And does doctor want a study model? And should we take photographs? And it seems like every single time an implant case, an edentulous space, a denture patient, whatever it is, presents, it's almost as if it's the first time we've ever considered that where you may place an implant. So I would start with creating standards of care in your practice and reviewing them with your team. So what data do I want? I need medical history. I need dental history. I need full mouth charting. Do I need study models? Do I want them mounted? Do I need photographs? Do they have to be cosmetic quality photographs, or could they be simple intraoral photographs with your iPhone? And then imaging to me is key. Are we taking radiographs? And if so, which radiographs? Are we starting with an FMX? Do we take a pan? Do we have CT, CBCT in our practice? You should. And if so, at what point do we make the decision to take a scan? Is that when the doctor asks us? Do we do it preemptively, knowing that he's going to ask us? What is our need? In my practice, new patients require a full mouth series of x-rays. We do one every 3 to 5 years. Our hygiene patients have 4 bite wings every year. If we're going to be extracting a tooth and potentially planning for an implant, we are going to be taking PA and CBCT of the area preoperatively. We're going to be taking the CT of the area after the extraction and graft are done. And then we're going to be taking a CT prior to placing the implant to make sure that the bone has matured and healed. And then we will typically take a post-operative PA, not CBCT, once the implant is placed to make sure that we have the right location and for our records. For larger cases with multiple implants, we may take a post-operative, post-implant placement CT scan as well. Now, I can assure you that my team is familiar with what our standards of diagnosis are. And so when we have a patient, whether it's a new patient, a consultation patient, or an existing patient who's coming through hygiene and is asking about implants, there's not a lot of back and forth between me and my team. They know what it is that I expect, demand of them with regards to data collection, and they have it ready for me for when I come in to discuss the case with patient. Treatment planning. You know, to me, there are three components to implant placement in the general dental practice. So component one is extraction. Are we starting with an edentulous space, or are we removing a tooth? Are we starting with a 3-unit bridge that the patient is unhappy with and we already have the edentulous space? Or do we have a tooth, whether it's a tooth that has an infection, a failed root canal, a fractured tooth that can't be restored, whatever it is? To me, the first phase in treatment planning for implant placement is more than likely going to be at some point the extraction of the tooth. So in my office, when we extract a tooth outside of a third molar, we're going to be doing some kind of ridge preservation grafting. Typically, we're doing some particulate allografting. We use membranes to cover over the grafts, resorbable membranes, collagen-based mostly. Although we also do PRP, and it's a little bit more advanced, perhaps for some of you that are just getting into implantology. So we're talking about extraction, ridge preservation with membranes. That's phase one of the treatment plan. Phase two of the treatment plan would be placing the implant after the ridge site is healed, 3 to 6 months, depending. And then the third phase is the restorative phase. Now, what I would urge all of you to consider would be at the first visit, when you're talking about extraction, you should be discussing with your patients, if at all possible, the full gamut of the 3 different phases of treatment planning. I see a lot of offices, they'll come in, a patient has a broken tooth, and their treatment plan is extraction of the tooth. And sometime during the visit, the patient sort of looks up, terrified as they always are, and says, so am I going to get another tooth? What do we have to do? When do I come back? What's going on? It seems like there may be a disconnect between where the patient's head is at and where the doctor and team's head is at. So in our office, we phase all of our treatment planning, but we review it with our patient up front, and which we'll get to, we also review the financial aspects of the case with our patients up front as well. If you want, you can provide the option for fixed partial denture, bridge, or removable partial denture, if that's something that you fancy. But obviously for tonight, we're talking about implants. For us, the 3 phases of treatment planning are going to be, how do we get to the spot where there's no tooth? What kind of implant and when are we placing it? And then how are we restoring this tooth? What kind of restorative methods are we using? And how do we discuss that with the patient? So typically in our office, a treatment plan is going to look something like exam, PA, CBCT, extraction, graft, membrane. Phase 2, implant placement. Phase 3, custom abutment and screw retained crown. The patient will see all 3 phases. We can create a timeline for those phases, and the patient will see the cost of all 3 phases, and they can decide how they want to pay for it, whether they do some kind of upfront financial arrangement, whether they use care credit or some kind of outside financing to do it, whether they put it on their Visa card and get the points so they can go to Myrtle Beach for the summer, whatever it is. I feel that patients are best informed and behave best if upfront they know all of the implications of the entire case and are prepared to move ahead with it before the extraction phase. Now, some patients may say, I don't want another tooth. I'm fine without a front tooth and I'm all good. So I don't need an implant, nor do I have any desire to put a bridge in. Just remove my tooth and I'm happy to go on. That's fine. That's their prerogative, and they can certainly make that decision. I don't know that it's the best decision, but at least you know that you've gone over all the different phases of the case. Now, as far as insurance coding is concerned, I can't get into the specifics of the ADA coding because of some of the restrictions vis-a-vis CE and the ADA. But what I can tell you is it's very important that you and your administrative team sit down with your CDT code book and make sure that your entire treatment planning is coded properly so that you know how to attach the appropriate fees to all of the different procedures that you may or may not be suggesting to your patients. There are codes for extractions. There are different kinds of extractions, surgical and traditional. There are different kinds of grafting. There's sinus lifting and sinus bumping. There's implant codes, abutment codes, and crown codes. Make sure you familiarize yourself. If you guys have specific questions about codes, you can email me and I can certainly discuss it that way with you. But during this lecture, I'm a little bit tied in what I can say. The most important part of coding is have those codes already loaded into your office management software and make sure that the appropriate fees, whether they be your office fees or the appropriate insurance fees, if you participate with insurances, are attached so that you're not adding to the stress of this kind of treatment planning phase, having to run around and figure out how much stuff costs. Now, case presentation to me is something that I think it always deserves a good review. Case presentation is something that I talk a lot about with my clients. And I'm going to give you guys just a quick 2-minute, the best way to sell dentistry ever kind of a tutorial. And if you gain nothing else from today about implants, I think this will be worth your hour spent. So first and foremost, we use a strategy called PCS. So it's problem, consequence, solution. All of your case presentations, whether they be implants or bridges or fillings or whatever it is, all of them should follow this strategy. It is very effective, very easy, very quick, and it moves patients to the point of sale very rapidly. So PCS stands for problem, consequence, solution. Most dentists are really, really good at solution, but not good at problem or consequence. So you hear things if you stand around a dental practice like, Mrs. Jones, I took a look in your mouth and it looks like you need a crown. A crown is a solution. A crown is not a problem. A crown is not a consequence. A crown is a solution. Or, well, you need an implant. An implant is a solution. So problem, consequence, solution would sound something like this. Mr. Krieger, you have a fractured tooth on the upper right. If that tooth is not removed, the infection that is there or the infection that is not there may get there. It may become a serious issue. The bone around the tooth may become damaged. Other teeth may become damaged. So the broken tooth may represent pain, infection, damage to other structures. And if you would like to avoid any of these consequences, my recommendation would be removal of this tooth. Once the tooth is removed, the immediate risk of the infection, pain, fracture is gone. However, you will then have another problem, which is a missing tooth, an edentulous space. Having a missing tooth or an edentulous space is an issue because we can have destabilized arches, we can have teeth that move, we can reduce chewing efficiency. There are a lot of problems with missing teeth. And if you would like to avoid these problems, I would suggest replacing the tooth. And here are the solutions that we sell to replace teeth. And then you can go through your litany of solutions. If you can provide a problem that is clear and understanding to your patients, and then attach consequence to that problem, then you can discuss with them solutions to a consequence that they want to avoid. If you go right to solution, most people will not understand consequence or that they even have a problem, and selling them something like an implant or a crown or whatever it is, a filling, may be very difficult. People do not buy if there is no consequence. The consequence may be that they really want it. The consequence may be that they're lonely and they want to come see you. The consequence may be that they have a wedding coming up and they don't want their two front teeth to be brown. The consequence may be that their mother had dentures and they don't want to fall into that same, difficult place that she was. So they want to avoid that. I assure you that people buy solutions to consequences that they are aware of, that they are concerned of, and that they own. What I find most troubling in dental offices and in practice management discussions is that dentists and their teams are not good at discussing problems and their consequences effectively. They seem very hesitant. They seem a little trepidatious about it, almost as if they don't believe that dentistry has serious consequences. Like, well, it's just a little cavity, or, well, so you're missing a tooth. God gave you 28. What's the difference? You have 27 now. I believe that dentistry is very important, that dental disease is critical in maintaining. And I believe that the problems that patients present with have serious consequences. So I'm very clear in a very direct, very meaningful way what those consequences are. I would also suggest that you stop using very complicated dental terms. You've paid for your degrees. We all know your doctors. Talk to your doctor friends that way. Use terminology that your patients understand. So you have a broken tooth and the tooth is infected. If we don't take it out, the infection will get worse and the bone around the tooth could become damaged. And if the bone becomes damaged, you could have major issues in your jaw, in replacing teeth, in chewing, in breathing, in snoring, in all of those things. And so if you'd like to avoid those consequences, which are very serious, I can put an implant into the bone and a tooth on top of the implant. There are great tools now on your iPad where you can show them a picture of what an implant looks like. They're animated, so it's very easy to see. You can pull up any kind of website. I have TVs in all my operatories, but problem, consequence, solution is critical for case presentation. You should also, as a team, you doctor and your administrative, I say this again, administrative and clinical staff should have a team meeting to discuss implant sequencing, timeline, and case presentation. So the common questions about implants are, how long does it take? How long do I have to go without a tooth? Does it hurt? Does it last forever? What is a bone graft? Where does the bone come from? I get a lot. Am I going to get a fake tooth or is it going to be a space there? What happens if the implant doesn't work? So as a team, you should sit down and talk about commonly asked questions and how to answer them so that everybody is on the same page with the same answer. And also you should discuss sequencing and timeline. How long in your practice does the process take? Everyone is kind of in a similar sphere of timeline because of implant healing and bone healing and so forth, so on. But you should have a consensus amongst your team of what it is that you're saying to your patients so that they're all on the same page with you and with each other, because your patients do talk. 6 degrees of separation, the world is a small place. So in my practice, we say that after the extraction, there'll be a period of 2 weeks where we're following up, and then 3 months for the bone to mature. At 3 months, we will do a scan. We call them scans. We all know that's CBCT. We will do a scan to ensure that the bone is mature enough to place the implant. Once the implant is placed, depending on the surgery, we will be waiting anywhere between 3 and 6 months until we put the tooth on. Now, sometimes after the surgery, I can change it up. That's my right as the doctor. If the bone looks fantastic, if I have great torquing, if I'm able to put that implant in, it's maybe a 13 millimeter by 4 and change, and it's solid as a rock, and the patient is young and has no health issues, maybe I can push the envelope to 2 months, 2.5 months. I know we're all about rapid healing, but when we're talking about case presentation and treatment planning, our patients are all kind of on the same timeline. So I'm going to get the tooth out. I'm not going to get the implant for 3 months, and I'm not going to get the tooth on the implant for another 3 months. And then we know what questions they typically ask. What is the difference between the implant and the tooth? Do they always work? X, Y, Z, P, D, and Q. And then finally, and don't be naive, if you're going to be answering questions, money is probably going to be at the top of the list. So when we're generating a treatment plan and talking about case presentation, the next component is going to be the financial arrangement. You should be ready with your financial conversation when you're doing your case presentation. So doctor does case presentation, i.e. problem, consequence, solution. Here's what I see. Here's what's going to happen if we don't fix it. And here's my suggestion as your doctor about how to deal with this problem. But team, whether it's your clinical support team, hygiene, assistant, or your administrative team, or you have a treatment care coordinator, a financial arrangements planner, or whatever it is that you want to call that person in your office, they should be ready and waiting already with the numbers. Because for most of your patients, this is a conversation about money before everything else. You could wow them with all your fancy dancy equipment and dental words and talk about how many courses you've taken and how many thousand implants you've placed. And typically the first thing they're going to ask is, okay, how much is this going to cost? Nothing wrong with that, by the way. Most of you shop that way. You see something you like, you kind of you feel it, look at it, walk around it, get a sense of it, and then you see how much it costs. And if the price of the item that you want to buy fits within your value system, $300 for a sweater is okay for you, and you want it, then you say yes and you buy it. So where you stand to lose the sale of the implant is in the speed with which you can go from effective case presentation, problem, consequence, solution, into money. The longer it takes you to get from here's what's wrong and what I sell to here's how much that costs, the less likely your patients become to buy what it is that you're selling. I assure you, this is not a Dr. Krieger-ism. This is all about psychological research. Dan Kahneman wrote a book called Thinking Fast and Slow. He won the Nobel Prize for how human beings think. And a synopsis of his 1,000-page brilliant book, again, Dan Kahneman, Thinking Fast and Slow, is that human beings do not use data to process and make decisions. They use emotion. They do it quickly. Their reptilian brain always takes over. And speed is one of the most critical components in getting people to agree to do that which you want them to do. So where I see offices fail in their attempts at selling all dentistry, not just implantology, but all dentistry, is all about speed from here's what's broken to here's how much it costs. Because as soon as it takes too long, your patients begin to think too much, to factor in too much data and move away from emotion, and therefore slow down and typically delay treatment or say no. And you've all seen this. You've all said, well, let me call you, or why don't you send me that treatment plan via email and I'll get back to you, or, I'm going to come in a month and we can talk about it. And that's a very nice, considerate way of your patient saying, I'm not going to buy this and I don't want to say no, so I'm not going to waste your time. It always strikes me as odd that you sell stuff. You have a retail sales and service business, basically. And it seems like no one is really ready to or willing to or prepared to discuss the prices of the things that you sell. And they always seem to be the most common question asked. How much is this? Just tomorrow, listen to your patients all day long after all of your brilliant, amazing, perfect case presentation doctors. The first thing they ask the team is how much? How much is this? Why are we always so shocked at that? Why aren't we more prepared? So once we know the price of an item, then what we have to figure out is, okay, I'm going to tell you how much it costs. Then I'm also going to tell you which ways we're okay accepting your money. Do you have to pay us all today? Can you pay us $5 a month for the rest of your life? Do we only take credit cards? Do we only take cash? Will we barter? When do I have to make the payment? Who makes the payment? You need to have a written, sound financial policy in your practice that everyone is familiar with, and it has to be ready and waiting for your implant financial arrangements, just like it would be for a crown or a filling. The challenge with, or the complexity to the implant process is, of course, time. A crown is typically a 2-week, or maybe if you're CAD/CAM like I am, a 1-visit deal, whereas implants may span 6 months, and they may span 2 calendar years, and they may even span 9 months or a year, depending on how the patient is presenting. So we need to be able to factor in the different sequences, extraction, implant placement, restorative component. how long they're going to take, how much time is in between, and what we as an office, what you as the owner of the business are willing to accept as acceptable financial arrangements. In some practices, if the patient doesn't pay for the entire treatment from extraction all the way through restorative, the dentist is not willing to proceed. In others, they break it up and say, look, I'm going to extract the tooth, you can pay me for that. Then in 3 months when we go to put the implant in, you can pay me for the implant. And then in 3 months when we put the tooth on, you can pay me for the tooth. I have my preferences. That's not what today's meeting is all about. I would suggest to you that the more important issue is not what my preferences are, but that you have a written and agreed upon financial agreement arrangement that your team understands so that all of your patients are uniformly handled in your implant process. We talked a lot about sequencing and protocols already. The one other thing I wanted to add to that, guys, would be how long do you schedule for each of the appointments? That should be something you've calibrated for your team and that they're aware of. There are obviously exceptions to all rules, but if I said to you, how long does a crown take? You probably could all vomit up some number like 90 minutes, 60 minutes, 2 hours, barring the extremes, the outliers. So I would say the same for you as far as implants. How long does your average extraction take? How long does your average implant placement take? And how long do your restorative visits take? And you should have them sort of outlined for your team to know so that when your patients are setting up appointments and asking, they don't have to come running around the office looking for you every single time you suggest something and say, how much do you need for this? How much time do you need for this, doc? Hey, how much time do you need for that implant? It's inefficient. It's quite frankly, it's a nuisance and annoying a lot of times. I'm trying to answer 1,000 questions and do 1,000 things. I don't want my team first having to ask me, how long do I need for an extraction, even though they know that I always schedule 1 hour for an extraction and graft. So why have the conversation if I always schedule X amount of time? There are exceptions. I understand that. Some extractions are complicated. Some implant placements are complicated. Some patients are complicated. But you should have a general rule. And you should also incorporate, guys, follow-ups. Just remember that if you tell the patients it's 3 visits to get this done, and you add 10 follow-ups in there, you've just lied to them about the 3-visit thing, and it's really 13 visits. So be clear. We're going to extract your tooth, and then 2 weeks later, we do a follow-up and suture removal. And then in 3 months later, we're going to do a scan. And after that scan, we're going to schedule the implant placement. And after the implant placement, we may do a follow-up 1 month later. And then we do a follow-up 2 months later. And then we take an impression to make a screw retained crown, or we scan to mill a tie base and zirconia crown, whatever it is. You should know how many appointments, what the intervals are in general, so that you can discuss them. This requires a lot of team meeting time for you, doctor, and your team to come up with your protocols for the visits and appointments surrounding implant implementation. The reason why dentists struggle with incorporating implants into their practice is not surgical. It's not clinical. Trust me, implant placement, once you get the hang of it, which takes a few implants, is really one of the simpler procedures you do. I'd rather place an implant all day long than do a molar endo or a veneer case. Surgeries, I think, have a lot more tolerance. What is challenging about incorporating or implementing an implant practice into your practice really are the logistical protocols that go along with it. And they're the things that we think about the least. We get excited about the drill and the motor and buying 1,000 implants, and we get a cool shelf system with labels and every different implant size under the sun. And we have all these cool scanners and milling machines. And, dentists, we love shiny technology buttons. But the truth of the matter is an implant implementation lives or dies in the business details of how we're going to move people through our practice with the least amount of stress and anxiety and tension and waste. And when we have these protocols set up and in place, we become more efficient and we can move people through our practice with less chair time and therefore increase our hourly revenue rates. We have less waste and therefore more revenue and more profit. and then we can have a more successful implant program. I assure you that if I give you all enough hours, you can put an implant in and get a tooth on it. But if I divide the number of hours it takes you to put an implant in and restore that implant by the number of hours it takes me to put that implant in and restore that implant, if I'm taking less time, even at lower prices, I'm more profitable than you. If you charge $5,000 from extraction through crown, and it takes you 100 hours to get the implant in, you're making $5 or $50 an hour. If it takes you 5 hours, you're making a lot more. You're making $1,000 an hour. So I would rather be generating $1,000 an hour in revenue than $50 an hour, $500 an hour, or $100 an hour. And a lot of that time is not because you're surgically slow or because you can't take a tooth out or because you're not good at implant impressions. A lot of that time is insidious. It's wasted time that comes in the form of, scheduling more follow-ups than we need, or not knowing we need to follow up and having to squeeze someone in, or not knowing that a patient needs a scan and having them sitting in the chair and waiting. And then all of a sudden doctor comes in and said, "Where's the scan?" And then you got to run to the scanning room and set the machine up. And that takes 20 more minutes. Or not having the right implant in stock and the patient's sitting there and you don't have a 10 millimeter, you have a 14 millimeter, and you're not going to put an implant in their sinus because you don't have the right stuff on site. Those are the reasons why implementation is challenging. And those are the areas where you can ensure, I think, more profit, more success, setting up those protocols. Now, there's your clinical protocol, which is probably why 90% of you got on the call to begin with, is super important. So, we have Benco and IDS. They can support you in your implant armamentarium, all the way from, I think, imaging through, CAD solutions, scan solutions, restorative solutions, impression solutions, and then obviously your implant armamentarium. So you're going to need your surgical kits, that's extractions, graft kits, sinus augmentation or manipulation kits if you're going to be doing that. Then you're going to need your implant surgical placement kit, your implant restorative kit, and then of course your componentry, your implants, healing caps, cover screws, all of those things that you need in order to be able to place an implant. As far as your armamentarium is concerned, I think once you've taken your hands-on surgical courses, there's some personal preference into what you're using, but you all obviously need handpieces and motors, and then you need to stock some implants. Now, I stock about 30 implants at a time, but what is great about modern business and commerce is drop shipping is everywhere. So I'm sure through your relationship with IDS and Benco, if you have 24 to 48 hours notice, you can get any implant you need in your office prior to the surgery if you're aware of it. So we do two things when we're talking about implant armamentarium. We stock basic implant sizes in a reasonable variety. We don't want to keep too much armamentarium because keeping inventory costs money. And then we have protocols that allow that if we have a patient scheduled for an implant placement, we are made aware of, my assistants and I have a period of review more than 48 hours prior to the implant surgery, where we are checking our inventory and then ordering as needed whatever implant we want to place. The implant size will be determined for me in my office, typically at the scanning phase, when I'm determining whether the bone, the site has healed properly, and I'm taking a CT scan to plan my implant. I am then telling my team what size implant I want, both height and width. Things change, I get it, guys, but I have a general sense, and they will verify that we have that in inventory. So Mrs. Smith comes in, tooth number 3 was extracted 3 months ago. The site has healed. We scan it, we measure it. We have implant planning software that comes with our CT machine. We can then plan and look at the sinus and the width of the bone and the height of the bone and the density of the bone and the interradicular space and say, okay, this is a good site for a 4 and change by 11.5 millimeter implant. Let's make sure we have that on site. And at least I know going in, I have the average implant that I think will fit. Now, I stock some other implants in case, but generally speaking, with implant planning software and CT scanning, there really should not be a lot of mystery about what implant you're placing. Obviously, if you're using stent-guided implant surgeries, and some of you, if you're getting into implants new, you're going to be using them, then there is no guessing. When you have the stent made, the stent is for one specific implant that's one width and one length, and that has to be on site. When your stent comes in from the manufacturer who is ever making it, whether you're making it on site or through a lab, as soon as that arrives and is checked in, someone should coordinate that there's an implant to go with it, and they are put in my office together in a lab box for the patient. So their stent and the implant designated for them go in a lab box, put their name on it. So when they show up, we have everything together. You need to review with your team, all of your team, by the way, your surgical setup, your restorative setup. And when I say surgical, I mean all phases: extraction, graft, membrane, sinus if you're doing it, PRP if you're doing it, and your implant placement and uncovering, whether you're doing one phase or two phases. So all of your team should be aware of what that armamentarium and surgical setup looks like. That way you can ask other team members for help. And that way there's not a lot of confusion in the practice about what instruments are and where they go and what is this for and what does doctor need. If you work out of more than one operatory with more than one assistant, if you have more than one dentist, associate, what have you, you should be calibrated on which systems you're using. And everyone should really be using similar setups in order to be most efficient. I go to a lot of practices where there are multiple doctors and they all have their preferences. And every time someone says crown, you have to have 300 different setups and 5 different impression materials and 12 different cements. If you homogenize the technology, the armamentarium, the inventory that you use, then you automatically become more efficient. So sit down as a team and go through what it is that you think best work for your practice and for each of its members, and create your armamentariums and let everyone know where they are. Do you have a surgical setup? Does it come in a kit? Did you get a kit with a surgical course that you took? Do you keep your implants separate from your other inventory? Do you have specific surgical kits that you use for implant placement? Where are they? Are they color-coded? Do you use cassettes? All of your setups need to be organized, and your team need to be aware of them prior to surgeries. Inventory management is complicated at every level in the dental practice. So we've tried to simplify it in our office as much as possible. So we do 2 phases of inventory management. Number 1, we have an inventory that we keep on site at all times. Every time we use an implant from that inventory, we restock it. So not rocket science. If we have 5 implants that are 5 by 10, and I use one of them, my assistant who is in charge of inventory knows immediately to order one more. We always have the same amount of inventory. And then our second sort of fail-safe line is, again, we have notes in our computer in scheduling in advance of implant cases where we know, let's say I'm doing an implant Tuesday of next week, Monday is a holiday, a note is going to pop up tomorrow that says implant placement Tuesday, size X and Y for patient Z, make sure we order. We put that note in manually in the computer so that when we're reviewing tomorrow's schedule, that note pops up and I know to sit down with my assistant and make sure we have the appropriate implant, bone, membrane, whatever it is. If you're doing PRP, so blood draw and platelet-rich plasma, you should make note of that in scheduling for the surgery so that the setup is there. And then as far as your lab is concerned, lab management can mean in-house management or external management. For those of you using impressions and making crowns off-site, you're going to be managing your cases through your lab. For those of you using CAD/CAM, 3D printing, milling, your lab management may be on-site. So lab management on-site would be making sure that you have the inventory on-site to manufacture the crowns that you need, the restorative component of the implantology. Lab off-site may mean what lab are we using for which crowns, what kinds of crowns do we use, what kinds of methods do we use? Is doctor screw retained or cement retained? What is the turnaround time for that lab so that we're not inappropriately scheduling? If our lab takes 3 weeks and we schedule the patient 2.5 weeks, you're going to have stress when that patient shows up and you don't have his case. You never want to rush your labs. They tend to be a little slower than they say, especially if they're courting you. So understanding your inventory, understanding your lab, understanding their sequencing and time frame, and making sure that your team is aware of all of the different components that need to go to the lab in order for you to receive in return a successful a prosthetic case. So what do we send? And there should be agreement, consensus. Maybe it's imposed through the doctor or through team meeting of what it is that we want to send to our lab to make sure that we have a successful case. And then we should try and do it for every case, whether we're doing a single crown or whether we're doing full reconstruction. So photographs, models, do we mount them? What kind of impression materials do we take? What kind of bite registrations do we take? What are the things that our lab gets? What do we write on our lab slips? Who fills out the lab slips and when? Those are all considerations that need to be discussed before you start placing implants. You're doing them for your crown and bridge, no difference for implantology. Where things become more complicated and where everyone is moving to, myself, I've already moved there, is when you're milling and manufacturing your prosthetics on site. So, we're going to scan the implant body and we're going to mill a zirconia screw retained crown. We know that we need tie base in the office. We need zirconia blocks of different sizes. We have already the different machines, zirconia oven, milling unit, so forth, so on. We have screws. So we have everything here to make the tooth. So when the patient shows up for their hour and 15-minute or hour and a half or whatever it is appointment, we're not scrambling around for inventory. So lab management, again, for some of you may be in-house lab management. For some of you it may be off-site lab management. I would suggest that you designate 2 team members to be in charge, always 2. That's a fail-safe. Summer's here, people go away for a week, and then you have no one managing your lab cases. And all, I'm sure, of your practice management software has some level of lab management built into the software where you can attach a lab case to an appointment card and check that that lab is in. And so when a lab case comes in from our lab, or when we order the right components for our in-house milling units, we can go into our software and check off an L, a little L that is attached to their appointment card. And you can see they're confirmed and there's an L, which means we have the right lab waiting for them for their Tuesday morning insert or delivery. You can also see if it's not there so that you have enough time in advance of that appointment to correct the problem or move the patient. It's okay to have to move somebody. It's okay to have to scramble and drop ship and call Benco in a panic. Hey, can you get me this? Or IDS, oh my gosh, do you have an extra 4mm implant? And it's okay to move someone and say, well, there's been a delay. We're waiting on the lab. We'd like to move your appointment out 3 days. What is not acceptable from a patient management and also from an efficiency management is having your patient show up and not have what you need and sending them home. It's a waste of time for everybody and a loss of money for you in your office. Once your implants are done, then you have to maintain the implants. And obviously recare and maintenance are super important. Now I've included in recare and maintenance your pre-op and post-op appointments and your protocols. So how are we dealing with the extraction phase, the post-ops, the implant placement phase, the post-ops, the restorative phase, the post-ops? How are we tracking completion of the case so that we're no longer we no longer have a lab box hanging out there. We no longer are running around looking for this patient. We've completed the case. We've set it complete. How do we make sure that they're going through hygiene in the appropriate fashion? And are we making note for our hygienists that our patients have an implant or multiple implants or an implant prosthetic, different hygiene visit, different instrumentation, different armamentarium? And then finally, maintenance and recare also to me is unscheduled tracking. So how are we tracking those extractions that didn't turn into implants, or those implants that haven't come back for crowns, or those impressions or scans that were done that never came to fruition? The patient is still walking around with a healing cap on 3 months after we took the scan or the impression. How are we tracking that in our software, and what are our protocols as a team for practice management's sake? What are we doing to make sure that as few people as possible fall through the cracks and as many people as possible are appropriately tracked and brought back into the practice to optimize revenue and optimize patient care. You know, we don't want to allow our patients to sort of leave without appointments and have to find their way back to us to get their implants done. So do we have processes and protocols built in with our software, with our team, whether it's the old school index cards or whether it's with our practice management software? Do we have them in place to allow us to properly track our patients? And then, you know, it looks like for the first time in my life, I'm on schedule. And then finally, marketing. You know, if you're going to be adding implants to your practice, the easiest, most effective method for letting your patients know is in your internal marketing and your office management software, patient communication software, and your platforms. Word of mouth amongst your patients travels really quickly. Like I said, 6 degrees of separation. If you decide that you're going to be placing implants in your practice, I would make sure that through email, text, through your different social media platforms, that you make announcements and incorporate announcements to the SED regularly about your implant practice. Discuss it even with your referring doctors, your surgeons. Let them know, you know, so-and-so, Dr. Smith, I've referred you 1,000 implants over the last few years. And, you know, I've decided I'm going to be doing some implants in my practice. It's time. They'll be happy for you, believe me. And so I wanted to let you know, just so that you're aware, we do now extractions and grafting and simple implant placements, and I'll send you the more involved, complicated cases. I would be sure that you are internally communicating with your patients regularly about everything going on in your practice, but certainly there should be some pomp and circumstance if implementation, if incorporating implants is something new to your practice. I assure you, for the vast majority of your patients, they want to have all of their procedures, all of their dentistry done in your office. They do not want to have to go to multiple specialists every time they need something done. Oral surgeons are amazing and they do a great job, but there's a lot of stress and a lot of complexity and logistical challenges involved in referring someone out every time they need an extraction, or extracting a tooth and then referring them for an implant follow-up. Your patients will find tremendous value in you doing those procedures in your office. So again, Facebook, Instagram, your digital communication, whether you're able to send mass emails out, if you do a hard copy mailer or you do a virtual mailer, if you follow people that are tagged on your website, all of those areas should be telling your patients and announcing to your patients that you are now placing implants. You should add information within your office, whether it's in your waiting room, in your operatories, about implant placement. And you should have, as part of your examination and conversations, a regular discussion about implant dentistry. All of those are really very important as far as marketing. Now, advertising that you place implants, I think, is something that you should do, and you should incorporate the services that you offer as part of your advertising platform. But what I can tell you about implants and advertising are that an implant is not a novelty anymore in dentistry. And there are hundreds, if you're in New York or New Jersey, thousands of dentists that are already placing implants in their practice and already advertising that they do so. So adding implants or developing an entire advertising campaign strictly around the fact that you place implants is not in your best interest from a success standpoint, because you are not the first to the table in doing it. There's nothing unique about it. That would be like Toyota having an advertising campaign that says, we sell cars. Well, so do a lot of other people. We already know that you sell cars. Perhaps what is different about the cars you sell, price, time, digital imaging, so forth, so on. But simply the fact that you sell implants and even sell them on price is not the avenue. What we talked about when we started this webinar, as we're wrapping up, is you already have patients. If you want to grow your business, the two easiest, least expensive, fastest return on your investment ways to grow your business are do more procedures on your existing patients and do new procedures on your existing patients. So your marketing should really be focused on the patients you already have and letting them know that you place implants in your practice. That is where your marketing, your internal promotion should be focused. As far as external advertising, outside of SEO, I am not a big proponent of it as a unique methodology. If you have an ongoing advertising campaign, television, direct mail, media, add it as a service that you offer. But I would really be focused on the 500,000, 1,500, 2,000, 2,500 existing patients that are coming through your practice regularly, the referrals that they bring in, and the services that they already need. So I just want to go over some quick revenue scenarios, and then I'll open it up to Q&A. It's just about 8 o'clock. So when I first incorporated implantology into my practice, and I looked back at the numbers and the revenue, I isolated the different revenue streams that came from implantology as an option. And then I looked at the first year of incorporation. So here's a little study of my practice, although I have many from my clients. I'm letting you guys into the one I have here. So just a caveat, the fees are averages and they incorporate within them usual and customary fee for service phase all the way down through PPO fees. So you may find them to be on the low all the way to the high side. So for example, here, extraction, $200 to $500. For a PPO patient in my practice, I may get $185 for an extraction. For a fee for service patient, we typically charge between $400 and $500. So you'll see the fees vary. And for implant placement, you can see $1,500 to $2,500. I know some offices are charging as much as $3,000. I've seen advertisements for, $49 for an implant or $995. These are our average fees looking at my office management software and my CDT coding and generating our reports. So all of these different areas to me are attributed to my implant practice. So extractions, grafting, tissue regeneration, guided tissue regeneration, membranes, sinus augmentation, implant placement, and of course my abutments and crowns. All of those are part of my implant practice. The more implants I'm able to place and the more complex the implants can be, believe it or not, the more extractions I do. I'm more likely to look at tooth number 3 that has been root canaled and crowned, that has reinfection at one of the apices, and instead of apicoectomy or retreatment of the root canal or antibiotics and hope and see, I'm more likely at this point, knowing how easy it is and how well integrated implants are in my practice, I'm more likely to say the best long-term option here at 40 years old with this tooth that's reinfected is removal of the tooth, bone grafting, and an implant placement. That's the most predictable option you have. Here are the other alternatives: specialist, endodontic retreatment, apicoectomy, root hemisection, blah, blah, blah. But in my mouth, this is what I would recommend. And because I'm able to do that here in my practice, I'm more likely to successfully sell that kind of procedure. So here are the different revenue scenarios. And here's what it looked like first year. So in my practice, these are the quantities of procedures done. The first year we did 50 implants after we did our surgical training. And total revenue from all of the different streams was almost $300,000. Now, at 60%, 57% overhead, you could see that there's almost $150,000 in profit built in to the first year of implementation in my practice. Now I'm definitely more advanced in my training at this point, and I'm able to do a lot more implants. We probably place somewhere between 3 and 10 a week now, and I can do more advanced surgeries and sinus lifting, so forth and so on. But in our first year, we were doing almost entirely entirely stent guided surgeries, single and sometimes multiple unit implants. We weren't really doing a lot of overdentures. Now we're doing a lot more, and we were doing very minimal. You can see sinus lifting, very minimal sinus work. So in the 2, 3, 14, 15 maxillary posterior area, we were sort of staying away from that area and limiting ourselves to, let's say, premolars and forward on the upper, and then the entire lower arch, depending in the posteriors on the inferior alveolar. Now, of course, I've expanded and I can place an implant wherever I want because of the sinus surgeries that I've been able to do. But in the first year, you can see that through successfully incorporating implants into the practice, we were able to add almost $300,000 in revenue. And for most practices, that's just a massive shift in growth and profitability, in the value of your practice, and also in the profit and revenue directly to you and your team, of course, who can share in the success of your practice. So it's been an hour. It's 8 o'clock. I'm going to stop sharing. I think I have to do a Q&A. And if you guys have questions, I'm happy to hang around. Here's our website. And if you need to email us and ask me some questions, fine to do. If you have a pen and a paper, you can take my direct email and my cell phone. I'm happy to give them to you. It's Dr. Krieger, drmkrieger @yahoo.com. So DRM Krieger, IEGER @yahoo.com. And my cell phone, if you want to text me, is 201-615-4630. Again, it's 201-615-4630. If you're interested in learning more about what we do, or if you have some questions, you can email me directly or at $1,000,000PPO.com. So
we have some questions for you. So you want me to read you the first one?
That's great, Kay. Thank you.
Yeah, that'll help you out a little bit. So great job on your presentation. It was amazing. So they want to know if Benco and IDS provide the same day shipping to arrive the next day if there is an emergency. So I don't know if Catherine wants to come back on and answer that. Catherine, are you still there?
Yes, I'm still here.
Okay, you want to come back on that? So that might be directed to you.
Yeah, Catherine, that's a you question. Just so long as I'm clear for Catherine, by emergency, you mean should a case arise that you weren't prepared for and you need something next day? That's what you mean by emergency?
That's what I'm thinking they mean, correct.
Okay.
And the answer is yes, certainly.
Yeah, I mean,
fantastic. Go ahead.
You know, what I can assure you is between your field representative at IDS and their on-site dropship department, if you're in need and you have 24 hours, so if you want to try and do a case tomorrow, between their field reps locally and, and FedEx and UPS, getting an implant is not a complicated thing. An hour or two, probably really hard, but a day or two, very easy to do. Our protocol, Kay, is 48 hours before surgery, we check our inventory. That gives us time to order any implant we need from anywhere to get to our office. 2 days is more than enough.
That's a great protocol. So fantastic. So the next one is, have you heard about GCL Systems and their gingival cup link?
I have not.
Catherine, have you?
I have not.
Okay. Do you use any ridge implants?
No.
Okay. What do you normally tell the lab on your lab slips for your implant crowns? What type of crown abutment do you typically ask for in the posterior and also the interior?
So if I'm using a lab and I'm not making them on site, I would say I ask for a screw retained zirconia crown in the posterior. And if space allows it, a screw retained zirconia and or Emax crown in the anterior. If space does not allow it, I would ask for a custom zirconia abutment and either zirconia or Emax crown.
Fantastic. And then
all cases are unique. So I'm giving you sort of a general sense. It really depends on the specifics of the case. So I may be doing 10 crowns, 1 implant, all Emax, so I would have to match. If I'm doing a single unit, I have a little more flexibility, but if I could say, I prefer screw retained as often as possible. It's just easier for everybody. And I prefer white over metal as often as possible. So if I can get a zirconia abutment, full contour or partial contour, I'm always wanting white versus metal.
Fantastic. And then the next one is that, can you please repeat your email address again?
Sure. It's Dr. M. Matthew Krieger, Krieger @yahoo.com.
And then is your fee and case based on the degree of difficulty?
Unfortunately for you guys, all the dentistry does not allow that. We, at some point, really messed up. Well, I almost slipped there and used profanity, but we messed up big time. And we didn't do what lawyers and mechanics and plumbers did. We are fee for service. So the way that the entire profession of dentistry works is that you do a procedure. The procedure is coded, CDT 88 codes, and those codes have a fee attached to them. And for most practices, and especially practices that participate in any way with insurance, the fees are set based on the codes. So charging for degree of difficulty is not something that we're able to do. You hope that the law of averages allows that some of your cases are easy and some of them are hard. You charge the same for all, but no, you cannot do that, especially if you participated anyway in insurance. There are areas in practices where I find dentists undercode the procedures that they do. So there are codes that they could be billing out and attaching fees to. So I would suggest evaluating what it is that you're putting in your treatment plans. But no, you cannot, I do not charge for degree of difficulty. I also find just from a clinical practice management perspective, most of your degree of difficulty is not surgical, it's not technical, it's practice management. You're not prepared for your case beforehand, and that's when it gets complicated and time consuming. Whether that's because you weren't set up, you didn't use the right lab, you don't have the right diagnostics, you didn't review the case appropriately and plan. Dentists get themselves into trouble time-wise, not necessarily because a tooth is so technically involved or an implant is so technically involved, but because in the planning phases, they missed something. So I would suggest that if you want to reduce the stress of degree of difficulty, it's all in the planning phases. That starts with great CBCT, implant planning software, working with a great lab technician, working with a great stent company, understanding through your partnerships with your suppliers and manufacturers and technology reps, how to use the equipment that you have. And if you can remove the degree of difficulty, then you don't have to worry about that. For me, a 12-unit veneer case, even on the most difficult of patients, is the same amount of time as on the easiest of patients, maybe a 15-minute difference.
Okay, then I don't think I asked you this one. How often, when doing an extraction, do you need bone grafting, and what type of bone grafting do you recommend?
So, outside of third molars, I graft for ridge preservation 100% of the time. So, if I'm extracting a tooth, I'm grafting. I use particulate allograft material. I have a certain particle size that I like. Different manufacturers have different particle sizes of the particulate bone. You could sit down with your rep and discuss what different sizes they have and which best for your practice. I use allograft, so that's particulate bone, and then I use collagen resorbable membranes 90+% of the time, or I use PRP membranes that I manufacture in my office. So I draw blood and I make my own membrane, and I use some of that PRP to augment the bone, but I use particulate allograft.
Yeah, I'm with you. I would rather definitely add it. And then if you don't need it, I would rather have it ahead of time and not surprise them later, the patient later. Let's see. So Wendy wanted to make sure that we do let you know that, yes, we do provide same day shipping. I mean, it usually arrives the next day with no problem. So Wendy, thank you for letting me know that. And then also, what do you use for screw retainer crowns?
I use screw retained crowns. I didn't.
Well, it says, what do you use? Wait a second, it's moving around. What do you use for screw retainer crowns?
So I use a zirconia crown that's retained by a screw. I don't know that there's more to the answer to that question. My lab fabricates a zirconia one-piece crown. The screw, the abutment component and the crown are one single piece. There's a cylinder in the crown. The screw goes through the cylinder, and then I close that cylinder with Teflon and resin.
That's fine. And then are you comfortable? They're asking also, like, what lab do you use?
I'm not comfortable answering that question.
Okay, that's fine. So that was all of the questions. So Alyssa, if you want to bring up our ending slides, I would appreciate it. So definitely we want to thank you both for being on. It was a fantastic webinar. And everyone that attended, we will get a copy of those Q&A questions out to them. And Catherine, are we going to be sending any other information out from you also?
Yes, we can definitely send out the live surgery course information.
Fantastic. So if you'll just get that to Alyssa, we'll make sure that we get that out to them. Go ahead, Alyssa. And then please make sure you scan this QR code. This will give you our upcoming webinars. It's really simple. If you scan it, it'll take you to our website. That way you'll be able to see them and also register for them. So again, just scan the QR code. And I want to tell you about 2 upcoming workshops that we're giving. This one last year, this radiology course sold out really quickly because it's one of the requirements in a lot of states. So if you're needing a radiology course, it's going to be for 2 CEs, 2 hours. It's going to be on July the 16th from 1 to 3 Eastern time. So all you need to do is go to shop.benco.com. And it's always nice to have this item number. Put in the item number 5750-841. And that way it's really easy when you get on there and you can get registered for that. It's $49 a person. So if you need radiology, please sign up. And then we have one other course workshop coming up. And it's going to be on OSHA. So if you're needing to get an OSHA course, Dental Enhancement, Jill from Dental Enhancement is going to be doing an amazing course on August the 6th from 1 to 3. And again, it's going to be for 2 CEs. And all you have to do to register is go to shop.benco.com. And the item number for this one is 5826-591. And if you have any questions, you can definitely email us at practicecoaching@benco.com. And Alyssa, I know, will get right back with you if you have any questions at all. So again, thank you so much. Please make sure when you receive your CEs, you're also going to be getting a survey. Please make sure you fill those surveys out. We want your feedback. We want to know what you want to see more of. So let us know so that we can make sure that we take care of you. Again, Dr. and Catherine, thank you so much for being on with us this afternoon. We really appreciate it. It was a fantastic webinar. Thank you.
Thank you. Have a good night. Happy Memorial Day. Be safe.
Yeah, be safe, everyone. Bye-bye.
Bye.